Okay? I think I heard it. Is that the CAH? How are you? So he's coming. Really? Pardon me?
So does this monitor as well come out?
Sorry?
Does this monitor come out?
Yeah, it does. Yeah. And that's someone just turned it off before. Okay. Yeah. Sure, I'll open it up. Yeah, no problem.
Jesus, it's falling apart here.
Right. Well, I had the site constantly hanging up. And so that's ready to go. Excellent. And look at these.
Whatever you
yeah.
Yeah.
Check. Oh, hi, Beverly. How are you doing?
Good. How are you?
Good.
I'll stay for the.
And then I can go to pocket, I suppose.
Okay.
Or click it somewhere.
Yeah.
Okay. And then you can. That was good too. Now we'll close the door. Yeah. Okay. Yeah.
Thanks. Good morning, everybody. Welcome to Grand Rounds. It's a pleasure today to introduce Dr. Gordon Francis. Some of you know him, some may not. He's the director of the Lipid Clinic, and he's going to be speaking to us today with the title of the Grand Rounds, Sine qua non.
Thanks, Barry. That's part of the title. So I'm not a Latin scholar, but I thought of this, and I didn't really know what it meant, and I don't know how many of you are Latin scholars, but a sine qua non is something absolutely essential or indispensable. So here are some examples. You can't have chocolate chip cookies without chocolate chips, and you can't fly a kite without wind. So since there's a couple of nons in the title, I thought that might work. And so I'm going to talk today about non-fasting lipids and non-HDL-Cholesterol and try to convince you that these are, in fact, essential and indispensable parts of assessing lipids in a lab report and how we use these now for lipid management and patient care. So this is my one disclosure. I'm an advisor for Axia, who make an orphan drug to lower triglycerides, and we're involved in a clinical trial with that medication. So the objectives are to help you recognize the advantages of looking at non-HDL cholesterol as compared to LDL cholesterol when you're assessing someone's cardiovascular risk and when you're trying to achieve risk targets for reducing cardiovascular disease, and to understand why there's now a move in the Canadian Lipid Guidelines and in the Canadian Family Physician Guidelines now for several years actually to use non-fasting lipid testing over fasting testing. So the clinical problem, obviously, that we're trying to prevent is atherosclerosis. Atherosclerosis in the forms of ischemic coronary heart disease or stroke or peripheral vascular disease is the leading cause of death in the world. It's also the leading cause of death in people with diabetes, and it's the leading cause of heart failure. So if you do things to reduce atherosclerosis development, you will help a lot of people and reduce healthcare costs to the system. So how important are lipids among risk factors for coronary heart disease? We've known, what the major risk factors for heart disease are for a long time, and they're listed here. These are the modifiable risk factors. But this study, published in 2004, actually looked at the relative contribution of different cardiovascular risk factors to people having their first myocardial infarction. There's 15,000 people all over the world, men and women, every continent of the world was represented in this study. And what they found was that the strongest predictor of having a myocardial infarction was a high level of ApoB-containing lipoproteins compared to ApoA1, which are HDL. So ApoB is on all of your non-HDL lipoproteins, and ApoA1 is on HDL only. So if you have a high level of bad particles over good particles, that was the cholesterol-containing particles, that was the strongest predictor of risk for myocardial infarction, followed by smoking, interestingly, psychosocial stress as measured by quantitative risk scores, and then diabetes, hypertension, abdominal obesity, and things that protected you against, with a hazard ratio or odds ratio less than 1, were regular alcohol consumption, regular physical activity, and daily consumption of fruits and vegetables. So we don't yet tell people to start drinking to reduce. People tell me they start drinking wine only because it's going to reduce their risk for a heart attack, but we actually don't recommend that. So non-HDL is what is represented as all the ApoB-containing particles are among the non-HDL cholesterol fraction. So since 2012, we have recommended in the Canadian Lipid Guidelines the use of either ApoB or non-HDL cholesterol as alternate lipid markers above and beyond LDL. So the fact that this parameter was introduced in the guidelines in 2012 resulted in most clinical labs all over Canada reporting the non-HDL cholesterol on every lipid profile. And that doesn't result in any extra cost to the lab. It's purely a computer calculation, which I'll show you. So what is it? It's kind of a funny name, non-HDL. What the hell does that mean? So it's total cholesterol minus HDL. So both total cholesterol and HDL are measured parameters in the lab. These are very well standardized assays. So you use 2 standardized measurements to calculate. Just subtract the HDL from the total cholesterol, and all of the remaining cholesterol is what's in the non-HDL cholesterol fraction. So that contains all of the LDL, and it also contains all of the cholesterol that's in other atherogenic lipoproteins, and that includes VLDL, IDL, and chylomicron remnants. So there has been some impression in the lipid field that LDL is the primary atherogenic lipoprotein. It's the one that can get across your vascular endothelium and get stuck in the artery wall. But there's good evidence that these other lipoproteins, even though they're larger, can also cross the endothelium and get stuck in the artery wall, including VLDL, IDL, and chylomicron remnants. The only lipoproteins that don't seem to cross the artery wall are full-sized chylomicrons. They're too large, but once they're quite rapidly catabolized by lipoprotein lipase down to chylomicron remnants after a meal. So the remnant particle is atherogenic, and so that's indicated here. This is a diagram of all the major lipoprotein classes present in plasma. HDL are the smallest, followed by LDL. Lipoprotein little a is an LDL-sized particle with another protein on it, and then intermediate density lipoproteins that are a byproduct of VLDL So every LDL in your bloodstream arises from a VLDL secreted by the liver. The triglycerides on these particles get hydrolyzed off down to IDL and then further hydrolyzed down to LDL-sized particles. And then the other group are the chylomicron remnants. So these are made by the liver, these are made by the gut. So non-HDL-cholesterol captures all of the atherogenic cholesterol that's in all of these lipoproteins, which all contain apolipoprotein B, and that's separate from the HDL fraction. So if you're going to believe this story, you'd like some evidence that in addition to LDL accumulating in the artery wall, there is evidence that these particles also accumulate in the artery wall. And there is evidence of that from the 90s. Borg Nordesgaard, who's one of the leaders in lipid metabolism in the world still, from Copenhagen, did a study where they infused labeled VLDL, intermediate density lipoprotein, and LDL into rabbits. And they found actually that the VLDL and IDL were retained more readily in the artery wall than LDL. And then another study from Spencer Proctor, who's a professor at the University of Alberta now, and his colleague John Mamo in Australia also infused labeled LDL, which shows in the red color here, or labeled chylomicrons, which show in the yellow color here. So they infused live rabbits with these particles, and then 20 minutes after perfusion, they isolated the carotid arteries. And so you can see the yellow chylomicron remnants are accumulating in the artery wall just under the endothelium, and the LDL are accumulating and seem to go somewhat deeper. And then they stopped that infusion, and in some of the animals, they allowed a 20-minute washout period. And then they again isolated the carotid arteries. And what they found was there's actually a little bit less LDL when you take it away, but the chylomicron remnants seem to be more retained. So this is possibly some evidence, along with that other study, that yes, indeed, these particles get across the artery wall, and they get stuck there. They bind to proteoglycans secreted mostly by smooth muscle cells. So there's a charge-charge interaction between positively charged ApoB and negatively charged proteoglycans that results in lipoproteins getting stuck in your artery wall. And this is happening to all of us throughout our whole lives, and that's what leads to atherosclerosis development. So particles besides LDL are also atherogenic. So that's shown diagrammatically here. So throughout our whole life, depending largely on the concentration of these particles in our blood, some will cross the endothelium and get stuck here, and then they can't leave, and they get modified, oxidized, aggregated, and get taken up by macrophages and smooth muscle cells to become foam cells, which are the sine qua non of the biochemistry of and pathology of atherosclerosis. So LDL contains about 70% of atherogenic cholesterol, and the remaining 30% is contained in these chylomicrons, VLDL and IDL. So it would seem to make sense to count all of the atherogenic cholesterol, not just the LDL cholesterol, when you're trying to assess a person's risk. So is there evidence that using the non-HDL cholesterol as a predictor of atherosclerotic cardiovascular disease is better than LDL? And there are several studies that indicate that, and one of them was a follow-up to a very large study that was done in the 1980s called the Lipid Research Clinics program. And as happens with many of these studies, like Framingham, they do long-term follow-up of people who are in these programs. And this was about a group of 5,000, pretty equal numbers of men and women. And over the follow-up period, they found that a 0.8 millimole increase in non-HDL corresponded to a 19% increase in cardiovascular mortality in men and an 11% increase in women. And when they compared that to the same 0.8 millimole change in LDL, the numbers were 15% and 8%. So when you look at equivalent amounts of cholesterol in either the non-HDL fraction or the LDL fraction and see how much risk that conveys, it seems to be higher for non-HDL. So that actually suggests that cholesterol captured in the non-HDL fraction is possibly more atherogenic even than cholesterol captured in LDL, and maybe for those reasons that I showed you, that those particles may be retained more readily in the artery wall than even LDL cholesterol. And then another study did a meta-analysis of all the big statin trials where individual patient data could be tracked. So they followed people for long periods, and they could, by individual patients, see what their starting LDL or non-HDL was, or ApoB, and what their on-treatment non-HDL, LDL, or ApoB were. And they found that among statin-treated patients, using this individual patient data, the on-treatment level of non-HDL was more strongly associated with risk of cardiovascular events than the LDL or ApoB level. Some studies have countered that and said that ApoB is maybe even slightly better than non-HDL, but in general, it's thought that both non-HDL and ApoB are better predictors of your risk for cardiovascular disease than LDL. And because non-HDL is a free test, and it seems to be at least as good as ApoB, the emphasis has been a bit more on tracking non-HDL than ApoB. Another interesting thing about LDL cholesterol estimation is that it's not accurate when triglyceride levels are elevated. So you've all seen lab reports where triglycerides come back higher than 4.5, and the lab doesn't report the LDL cholesterol level because they can't give you an accurate estimate. But the replacement of cholesterol on LDL by triglyceride level happens at quite a bit lower triglyceride levels, even greater than 1.5 millimoles per liter. And that's shown, this is a Framingham Offspring study showing that with increasing triglyceride level, LDL cholesterol levels tend to level off, whereas if they count LDL particle number, it's still increasing. So what's happening is this lipid transfer protein that we all have that you've heard as a target for lipid drug treatment, cholesterol ester transfer protein, it transfers cholesterol and esters and triglycerides back and forth between lipoproteins. So if you're someone who has elevated blood triglycerides, you have an elevated level of either VLDL, IDL, or chylomicrons in your blood. And the triglycerides that are in these particles can get transferred onto LDL in exchange for cholesterol. So you still have the same number of LDL, it's just they're relatively triglyceride rich, so that when the lab calculates LDL cholesterol, it's lower. But you still have a high number of LDL particles. And in fact, triglyceride-enriched LDL are more atherogenic because they can continue to be substrates for breakdown of the triglycerides by lipases. That creates smaller, denser LDL. Those get into the artery wall more readily, and they're more atherogenic. So as opposed to larger triglyceride-poor LDL. So this just means that if you have people with high triglyceride level, you can't really trust the lab estimation of LDL cholesterol to be telling you that you have achieved your goal, which is to reduce LDL particle number. And that happens even with triglycerides greater than 1.5. It doesn't wait till 4.5. It's happening at much lower levels. So there's a fairly big degree of error in the estimate of LDL cholesterol with increasing triglyceride level, and this study looked at that. So if you have an LDL triglyceride between 1.7 and 2.2, you have a 17% error, meaning reduction in the estimation of LDL. And if your trigs are 2.3 to 3.4, it's up to 25% error. So this is well before TG of 4.5. The benefit of non-HDL cholesterol is it's always how much cholesterol is in your atherogenic lipoproteins, regardless of how long you fasted or when you ate, and it's not affected by the triglyceride level. We have included this as a target in our guidelines as an alternate target. Therefore, Canadian labs report non-HDL. In the US, they haven't yet added non-HDL to their guidelines. Their labs don't report non-HDL. How many physicians do you think sit down and calculate non-HDL? They might, total cholesterol minus HDL, they sit there and do the math. Very few. They're not going to take the time to do that. So it means that non-HDL hasn't yet been adopted as much as a target in American guidelines. And there have even been efforts to come up with formulas where you can recalculate the LDL cholesterol based on the triglyceride level to try to back titrate or back calculate to what you think might be the real LDL cholesterol level. And that can get close to, but it's still not as good as the non-HDL cholesterol at the prediction of cardiovascular event risk. And it still doesn't take into account this pathophysiology of that other 30% of lipoproteins that are contributing to your atherosclerosis risk. So people are very wedded to LDL. You know, they've thought about LDL forever. You know, we look at what happens to LDL with statin treatment, and it's still the main diagnostic criteria for diagnosing familial hypercholesterolemia. It's just that the non-HDL cholesterol is actually a better indicator of a person's risk. So in the 2012 Canadian guidelines, we added a target for non-HDL cholesterol being less than 2.6 millimoles per liter. And it was recommended that you pay attention to this in anybody with trigs greater than 1.5 for all the reasons that I just said. And we have a threshold for non-HDL cholesterol. So in intermediate risk patients, based on Framingham risk scoring, if people are in the 10 to 20% 10-year risk category, we call that intermediate risk. And the guidelines recommend that if LDL is higher than 3.5, that they be considered for statin treatment. And in the presence of high trigs, you should pay attention to the non-HDL level. And if it's greater than 4.3, that should be your threshold for statin treatment. So here's a couple of cases that try to illustrate this. So this is a 58-year-old woman with known coronary artery disease. She's taking rosuvastatin 20 milligrams a day, tolerating it. She's got an LDL close to the recommended high-risk target of less than 2. She's sitting at 2.14. So you might say, well, I don't know if I really need to increase her statin dose, but her triglyceride level is 2.7, where again, you can't really trust this level, and her non-HDL cholesterol level is 3.38. So the recommendation then, based on the guidelines, would be to increase her statin or other LDL-lowering treatment to achieve non-HDL less than 2.6. So everything that lowers LDL, the statins, ezetimibe, PCSK9 inhibitors, all lower non-HDL as well. So you basically just need to intensify the treatment in order to achieve the non-HDL target in someone like this, where you can't really trust that this is achieving the recommended lowering of LDL particles. This is another patient I just saw a couple of weeks ago, 48-year-old man who had just recently been diagnosed with type 2 diabetes. So we consider in our guidelines, American and Canadian, anybody over 40 with type 2 diabetes as high risk, and that's a statin-indicated condition. In addition, his father had had premature heart disease in his 50s, and this patient was on no lipid-lowering therapy. LDL, pretty good, you know, not far above the recommended less than 2 target for someone with diabetes. But again, trigs are high, and his non-HDL cholesterol is high, and so is his ApoB above high-risk target. So again, the recommendation is to treat him with a statin and achieve either the non-HDL less than 2.6, if that's your chosen target, or ApoB less than 0.8. So we've started him on a statin, and we would titrate him to it. Like I say, achieve a non-HDL less than 2.6. So what does this cost? So in BC, thanks to Andre Matman for these numbers, this is what it costs to order a lipid profile in BC. So what the lab then does is, if you order that, is it measures the total cholesterol, it measures the HDL, and it measures the triglycerides. And from those three numbers, the LDL is calculated by a formula, and the non-HDL is calculated, which is simply the total cholesterol minus HDL cholesterol. So, and an ApoB is about 1660. So if you like ApoB and you want to use it as your sole follow-up measure of someone achieving lipid targets, that's reasonable. But if you want to use the non-HDL, all you actually have to do is measure total cholesterol and HDL, and the lab will then report the calculated non-HDL, and that costs a little bit less if you're very cost conscious. And there is, obviously a move to have physicians order fewer lab tests. So that is the most cost-effective way of following up the non-HDL and using that as your target. So it's just total cholesterol minus HDL cholesterol. It's immediately available along with the standard lipid profile at no additional cost. It's not affected by triglyceride level. It's not affected by how long it's been since you ate. And whereas LDL level is lowered by increased triglyceride levels, whether fasting or non-fasting. So in both the 2012 and 2016 Canadian Lipid Guidelines, we've advocated to use non-HDL as an alternate primary target. Our guideline panel wasn't comfortable enough just saying goodbye to LDL and just using non-HDL. I think that was maybe the better way to go, but it is, non-HDL is recommended as the primary lipid target by the International Atherosclerosis Society and the American-based National Lipid Association. So, based on this pathophysiology, it's a better indicator of risk, and it's a better indicator of benefit. When you treat somebody, non-HDL seems to be a better indicator. And these groups are not very pro-ApoB, not for any particularly good reason, but overall, the non-HDL seems to be as good an indicator as ApoB. So true or false, lipids should be tested fasting because there's wide variation in lipid levels following a meal. And I won't name names at all, but how many think this is true? If you eat, your lipids change. Nobody's putting their hand up. How many think it's false? Few people. So it's actually false that our lipids don't change a whole lot after we eat. That's always been the assumption and one of the bases for why people thought we had to do lipid level testing fasting. So a couple of big studies, one in Copenhagen and one in Calgary, have actually looked at this. How much do lipids actually change depending on how many hours after you eat in the general population? So in the Copenhagen study, they had over 100,000 individuals where they had fasting versus non-fasting levels. And in Calgary, they had over 200,000 individuals, cross-sectional study. And they looked at the variations in lipids, between 1 and 16 hours, up to 16 hours after eating. And what they found was that triglyceride levels increase only up to a maximum of about 20%. And the peak seems to be about 4 hours after you eat. So your gut is secreting chylomicrons, and the peak level in plasma after you eat is about 4 hours after. But even then, the maximum increase in triglycerides is only about 20%. And LDL is actually lowered by about 10%, and probably for the reason I said, the exchange of cholesterol for triglycerides on LDL. So these are not huge changes. They are significant, but not huge. But total cholesterol, HDL, non-HDL, and ApoB do not change significantly after eating. From both of these studies did not study, they excluded people who had a baseline triglyceride level over 4.5 millimoles. So they didn't study the people at the highest end of triglyceride. That's about 2% of the population. So we don't actually have values on how much lipids go up in people who start off with very high triglycerides, but that's a small percentage of the population. So, and then other big studies have looked at the predictive value of non-fasting lipids over fasting lipids for myocardial infarction, stroke, and overall mortality. And there's been, again, out of Copenhagen, as well as the Women's Health Study in the US and others, showed that increasing non-fasting triglycerides predict risk for MI, ischemic heart disease, and death in women and men better than fasting lipid levels. Another study looked at stroke and found that it also correlated better with non-fasting triglyceride levels compared to fasting. And the Women's Health Study looked at overall cardiovascular events, and that was better predicted by non-fasting than fasting lipid levels. Interestingly, it's not how much triglyceride is in those remnants, it's how much cholesterol is in them. So the measure of increase is in the triglyceride, but it's not the triglyceride that's atherogenic, it's the cholesterol in the remnants. And that's indicated here. And so this study, for example, actually measured remnant cholesterol and found that that was the predictor of the risk, not the triglyceride level. So I'm trying to figure out the reason I put this slide here again to remind you of something. So again, you know, we know that these remnants do accumulate in your artery wall like LDL does. And since in the 2016 guidelines, we actually now promote non-fasting lipid testing. So this has actually been in place in Alberta since about 2014. The Canadian Family Physician Guidelines went along with the Alberta lead and recommended non-fasting lipid testing starting in 2015. And so now since the 2016 which guidelines, which came out about 2 years ago now, we recommend non-fasting lipid testing as the norm for both baseline and follow-up lipid measurement, and continue to recommend non-HDL as an alternate lipid target. So the guidelines actually say that non-fasting testing is recommended for initial screening and follow-up testing of lipid and lipoprotein levels, strong recommendation, high-level evidence, the evidence being those Copenhagen and all those other studies that I just showed you, including the risk associated with non-fasting lipids. But for people with a history of triglyceride levels greater than 4.5, the recommendation is to continue doing lipid profiles on those people fasting, only because we don't have evidence for how much their lipids change after eating, and so that's considered a weak recommendation, low-level evidence. So, so the implication is that we move to random non-fasting lipid measurements as the norm for lipid testing. This doesn't affect the Framingham risk score utility because that's based on age, total cholesterol, and HDL, which don't change with non-fasting, blood pressure, smoking. And then in addition to that, continuing even in a non-fasting lipid profile, if triglycerides are higher than 1.5, that you use the non-HDL cholesterol as your parameter of interest and target, or ApoB, if that is your choice. So, so it doesn't really change how we interpret lipid profiles. We still recommend the same kind of targets. So if trigs are less than 1.5, it's okay to use the LDL as your target. If they're greater than 1.5, it's recommended to use non-HDL as your target. So what are the benefits of non-fasting lipid testing over fasting? As I showed you, there's enhanced predictive value for cardiovascular disease and mortality. So you get better information, and that's what I tell patients. It definitely enhances compliance with lipid screening and follow-up. if my GP gives me a lab rec and it says fasting, it'll sit on my desk for months and I never go and can't figure out what morning I'm going to take to go fasting. But if the rec says non-fasting, you can go immediately to the lab after leaving your doctor's office right away. You don't have to wait around. And so it takes pressure off labs early in the morning. Patients don't have to get up before they eat, go to the lab, wait in line with a whole bunch of other people. So, and the lab won't send you away if you haven't fasted, which they used to do. It's also good for preventing hypoglycemic episodes in people with diabetes. And overall, it reduces the need to perform fasting blood work generally. Some diabetologists still like to have a fasting glucose, but you can diagnose diabetes just with hemoglobin A1C, which can be done on non-fasting blood, and you can follow up diabetes with hemoglobin A1C. You don't have, hemoglobin A1C is a 3-month measure of average blood sugar control, whereas a fasting glucose is just a single moment in time. So if we don't require people to fast for lipids, there isn't a whole lot of reason why people have to fast at all for blood work. There are a few rare blood tests that are still recommended to be done fasting, but not too many. And patients are very grateful. They say, oh, wow, I don't have to go in early in the morning. So so this guideline came out in 2016. We talked to Andre and Dan Holmes about it. We talked to Life Labs. And there was a message out to labs to not send people away if they came in non-fasting. But they were still getting sent away for a long time. And even before the lab requisition changed, which is just about to, more recent data that Andre got for a commentary we have coming out in CMAJ soon, that as of March 2018, about 15% of outpatient lipid profiles in Vancouver Coastal Health were done non-fasting, and no tests were canceled because of non-fasting. So people weren't getting sent away because they hadn't fasted. So it takes time for all the technicians working in clinical labs to get used to this idea, right? And so it takes more than just publishing it in a guideline to make it happen. So what it really takes is a change to the lab requisition. And so we've also been working with Andre and the provincial Ministry of Health and Life Labs to come up with the new recommendation for lipid testing. This is not yet out, I don't think. I'm not sure if the Ministry of Health rec is out yet. But
it is out.
Okay. And I've been told by Life Labs that they're obligated by the Ministry of Health to change their lab rec by the end of 2018, meaning in January next year, this should all be on all the standard lab recs. So it'll read fasting, lipids. Fasting is not required for any of the panels, but clinician may specifically instruct patient to fast for 10 hours in select circumstances, e.g., history of triglycerides greater than 4.5, which is what we say to do in the guidelines, to keep doing those tests fasting, independent of lab requirements. So that applies to either a full lipid profile, so patients should have a full lipid profile reported when they come in non-fasting, including the LDL-cholesterol and triglyceride level. But there is still, a move to try to reduce overall lab tests. So it's still recommended that if you're not worried about a patient's triglyceride level, that you go with just the total NHDL cholesterol, and then non-HDL is reported for free. And as I showed you, that's the most cost-effective way to do it. Or you can still follow up ApoB, which on its own, which costs a little more. And if somebody has complex dyslipidemia, so we will often measure the lipid profile and ApoB. But even more and more in our lipid clinic, we're following up either just the ApoB or the non-HDL cholesterol. So it's weird to people to think, well, we've been doing it this way all these years. Why would we now switch to non-fasting testing? And so it's strange to physicians, it's strange to patients. So what I tell patients is we get better information by knowing what your lipids are after you've eaten than before you've eaten. And we get better information about your risk for heart attack, stroke, and mortality. And I also tell people that their lipids don't actually change that much. People come in and tell me they ate a big meal before I saw them, before the lab test, and that's the reason their cholesterol is so high. But it's not the case. It's a time average thing. It's not a single meal that does that. And it's much more convenient. So you can eat a meal and go straight to the lab if you want, and you also don't have to abstain from alcohol prior to testing. So we're also not telling people they have to abstain from alcohol for 24 or 48 hours before a lipid test. So these two things come together, non-HDL cholesterol and non-fasting. Because LDL can fluctuate with triglyceride level, especially after you've eaten, the non-HDL cholesterol in a non-fasting sample gives you the best indication of total atherogenic cholesterol, including remnants, and it gets around this potential reduction in LDL with increased triglycerides, and it's just a better indicator of a person's risk than LDL. So it's the preferred measure for both risk assessment and target achievement using a non-fasting sample. So I hope I've convinced you that these are essential and indispensable components of lipid management, and they need better names, non-HDL cholesterol and non-fasting. But anyway, so happy to take questions and comments.
More a comment than a direct question. I mean, for years we've used LDL. We have multiple numbers that mean a lot to us: 4.2, 3.4, 2.5, 2.0. And all of this new stuff is more reanalysis of old studies or basic science, and not the randomized controlled outcomes that we have with LDL that has to be a little.
Yeah, that's a good point. So, but in fact, most statin trials didn't aim to achieve certain LDL levels, which is the reason the American guidelines don't agree with targets. Because the way a lot of the statin trials and other lipid drug trials were done is you compare different doses or drug and no drug. You see what happens to average LDL with that chosen level of medication, and you report what was the average level achieved, right? It wasn't a target in the trial. So even using LDL as a target is kind of not evidence-based, right? And so but what you can do is go back and look at the changes in non-HDL. You have all that data is available, right? So you can go back to all those statin trials and see what happened with total cholesterol, HDL, non-HDL, and then look at how that affected risk. You're right, it's a post hoc analysis. But LDL targets were not part of these trials either. So it's just we're all used to LDL, and it's what everybody has talked about. But we know from all this information that it's better to count all the bad particles, right? Not just the LDL. And so it's going to take time to get people used to that. So we do have targets in the Canadian Lipid Guidelines, less than 2.6 for high-risk people is the goal. And that equates, if you don't have high triglycerides, that equates to an LDL of about 1.8. So it's actually a little bit more rigorous than the LDL target of under 2. So if you're achieving a non-HDL under 2.6, you're actually getting lower levels than following the total atherogenic particles and following the LDL.
Any other comments, Andy?
Thanks a lot, Gordon. With the new Canadian guidelines likely lowering the goal for LDL, I heard something about 1.3. will the new goal for non-HDL be imputed from that, or?
Yeah. So the comment is will we lower the recommended target for LDL further based on PCSK9 trial data, which shows that the lower you get LDL, even below 2, the fewer the vascular events are, and that remains to be seen. But if that happens, there will be a non-HDL target recommended to go along with that lower LDL. Yes.
Marshall.
Yeah.
Thanks very much. You mentioned, under what circumstances would you now do a full lipid profile? You mentioned the marked hypertriglyceridemia. Any other situations?
Well, you want it at baseline for sure.
Yeah.
But following up, it's probably not necessary in most cases. If you don't have high baseline triglycerides, you're not really worried about that. And even when triglycerides are mildly elevated, if you get down to the non-HDL target, which is if you're using that with statins or whatever, if you still have some residual triglyceride elevation, that's not particularly atherogenic on its own, as long as you've lowered the non-HDL cholesterol. So it's a good point. We can probably reduce the amount of lab testing we do in the lipid clinic quite a bit, and in general practice. Yeah.
What's your opinion about weekly versus HDL? Usually you can test.
I do both because I'm retentive, but I think it may be a little. Sometimes it may be overall even a little harder to achieve the non-HDL target than the ApoB target. So if you're being more proactive at reducing risk, I think non-HDL is the way to go. Yeah, and it's cheaper. Yeah.
Any other? Yes.
Is there any impact on renal dysfunction like on these tests at all?
Well, I mean, renal failure can cause dyslipidemia, and so can nephrotic syndrome. But most people with chronic kidney disease don't have those severe forms. And we know that statin treatment is beneficial in people with chronic kidney disease. It's one of the high-risk indicated conditions. And you can use the non-HDL cholesterol as your target in renal failure patients. Yeah.
Any other
questions?
Questions or comments? Did you have a question? No. Sorry, just waiting. Well, thank you very much.
Okay.
That was very interesting. Thank you. I always learn something, and you taught me something.
That's good. That's the goal.
The only reason I put up my hand was you said at the beginning that you're not testing, you're not using fasting blood sugars or fasting to test HDL lipids. So for those of us who are listening to the beginning of your talk,
Yeah. All there. Not well, but your plans? Not in the last few weeks. I have, but
Just leave. Like 50% year of research with you. Maybe remove 50% years of research with you to make up. I take it you would be in favor of that if you were interested.
Yeah, but I'm not going to force him.
Yeah.
If it's what he wants to do, we don't.
It's hard to know how much of this is driven, because I haven't actually got a chance to talk to him, but I don't know if he's actually got a job offer. I don't know that. There's a rumor that may be what's going on, but the official story he told me was just that he was told he must leave Vancouver and join the division, and therefore, which...
Well, I don't think that would be the case. I think if he did research that people thought was valid here in Vancouver, I don't think we'll be doing an additional year or
but it just
depends whether he wants an academic position or... I think that's a bigger question.
Yeah,
not the leaving.
It may be too late to make that work. but it's good to, as I really thought this was all going through, is we actually have the raw mass and everything we talked about.
Oh, with him joining
yeah, because we have the clinical spot, and this was talking about what if you do 2 years, 50% myotic.
Well, I'm going to be seeing him soon, so I can I'll talk more to him.
Yeah, so it may be that he really has something else, but you know, it's still, and Marshall, reconsider certainly if you're on board with.
Well, we're happy to provide a training environment.
Yeah,
for sure.
Yeah, so I feel like
and that,
2 years of 50%.
A year ago, that's what he said he wanted.
But actually, 2 years of 50% is actually better than 1 year of 100 because you get more done at that time. Thanks. Okay, the meeting tomorrow. Okay.
So,
because it's coming out. To be honest.
I don't know, maybe he really has a better offer, but that wasn't what he said to me in his email saying I'm not what he was saying as well when I was last week in Vancouver.
No, that's not good.
Yeah.
Hi, I just wanted to introduce myself. Sylvie Champagne. I was fascinated by your talk because I'm one of those friends who live in the gene as well, and I'm founded by the Healthy Heart and and they still gave us as letters temporal to the requisition that you have to be fasting and no alcohol.
We're not up to date on that yet. You're right.
So last night I was there, I got my blood test this morning. I said, I really want my glass of wine, but oh gee, maybe I feel so guilty.
We just heard that the provincial lab was officially going to change. So we waited until that was happening before now we have to officially change our clinic requisition. But you're right, it's still the old method and we're getting up to speed.
And
thanks for telling me.
I also want to tell you that I believe you are my new neighbor in Duchess.
Oh, really?
Yes, we are.
Where?
Plus.
What address?
1247.
Oh, we're 1258.
Yeah, so you I'm the gray house.
Oh, nice.
Just
You're beside Mark.
That's right. Mark is there. We are in the tax. So we can, in fact, the window, we can look through.
You've seen all our remnants going up, yeah.
It's,
we're doing a lot.
You're doing it up.
Yeah. More than we originally anticipated.
Oh, really? So what are you doing?
Well, we put in a sprinkler system. The house has a suite. So we were sort of obligated to bring it up to code, and that required that we then take out most of the drywall to put in the sprinkler system. And then we're re-insulating because we can make the house much more energy efficient. So it's going to be a much better house.
Great, thanks a lot.
Okay.
I got to run and catch shuttle. So
okay. Learn something.
So, yeah.
Where do you work?
I work in microbiology there.
Okay.
So we're all the way. And my husband
You're a lab physician?
I'm a lab physician.
Okay.
Yeah. And my husband was a neonatologist at Columbia.
Okay.
So that's what we moved. We
so
used to live in Coquitlam.
Your first name is?
Sylvie.
Sylvie.
Yeah, that's right.
Great.
Nice to see you.
Yeah, so my wife is Eva. So,
I think
we met at tax, and
you did? Yeah.
we know the Stewarts next door and the Berries next to on either side of us.
Okay.
And, it's a nice neighborhood.
It's
great,
lovely.
Great
How
many years have you been there?
Well, we bought 15 years ago, but we built the house 2 years ago.
Just you.
Yeah.
Okay.
So
you built like from the ground up.
From the ground up. It looks like an old house, but it's not.
It's a nice looking house. Yeah.
It's just a design. It's a very modern home. We put an apartment downstairs.
So you have a rental suite.
Well, that was my daughter that lived there. I'm not going to be renting, but she just bought the house behind us on Eskimos.
Oh.
So
Great.
she's going to be moving there.
She can save money because she's living with you.
Yes. Time to move now. Thank you for your time.
Okay, see you later.
Young man, good job. Probably should have done cardiology.
Yeah, I was going to say. I mean,
because this is
okay.
It's a very simple, clear message.
Yeah.
And you know, the cardiologist. Yeah, I mean, it's most of the lipids are going to be the same. Most of the
I was going to
most of the
say
secondary prevention is all done here. But you know, people want to move beyond 2.0. You know that.
Well, yeah, there will be an equivalent drop in non-HDL target for sure.
Good.
So, sorry, I don't think we have.
I'm Katrina.
Oh, hi. We get a fair number of residents coming through the prevention clinic.
Yeah.
Yeah, I'll walk back.
Nice to meet you.
Sure.
I'm just wondering if this is used at all with cholesterol ratio.
We're not really that
Okay.
much. It's still reported the
Yes.
low ratio, but the non-HDL is a better.
Okay. I'll thank you. Very helpful. Thanks for the talk.
Not well. Yeah, we could just call them back to control and give them a productive call so that we can get them off the airport.
Do we give you these?
Yes.
Oh.
Thank you.
I'm gonna email you.
Alright. And then, so, what's the goal to get off? Yeah. How's your day going?
Pretty good.
Yeah.
Are you?
ATP MSI state.
Pardon?
ATP MSI state.
Juniors.
Where is your half day? Is it here?
It's here. It's
The other room.
oh yes. I think Tyler's. How are you doing?
Your call will be disconnected.